Welcome to Smoke and Mirrors, the podcast that cuts through the noise of the many policies and regulations that affect American agriculture. Each week, we pull back the curtain on the programs, policies, and perceptions shaping the agricultural community in rural America. If you've ever felt like something doesn't add up, you're not alone. I'm Jenny, and this is Smoke and Mirrors. Let's make sense of the maze we call farm policy. Welcome to Smoke and Mirrors, the podcast where we make sense of agricultural policy. I am Jenny Ift. I teach agricultural economics at Kansas State University, and I'm here today with Dr. Thea Sakata of Intermountain Health. She's a family medical provider. We studied land economy together in England.
My name is Dr. Thea Sakata. I am a family doc. Went to med school at Northwestern University and then did my family medicine residency out here at the University of Utah. And I stuck around in Utah because I really like the mountains. And now I work for a healthcare company called Intermountain Health, which is a large healthcare system out here in the Intermountain West. Thanks for having me.
Oh, absolutely. Before we get started, I just want to say, so part of my job is extension and outreach. It involves explaining economic concepts and research, sometimes to farmers, sometimes to bankers, sometimes to policymakers. So you really have to sort of cut to the chase and get what's important and say it in clear terms that make sense to people. And, after I thought about reaching out to you, I realized that's actually a big part of your job, too.
Well, it's a little bit part of my everyday job in that I need to teach people about the conditions that they get diagnosed with.
So, doctor and agricultural economist, we have a lot in common still.
As the granddaughter of a lettuce farmer, I'll try to pretend like
Yeah, one of the reasons I thought about reaching out to you, with the Make America Healthy Again, MAHA, gaining prominence. I'm an agricultural economist. I don't know a lot about public health, and I don't really understand chronic disease. And I wanted to get the perspective of it from somebody who's dealing with it on a daily basis. But do you mind just start off defining what chronic disease is?
Yeah, absolutely. Chronic disease is actually pretty common. Something like 6 out of every 10 people in the United States live with at least one chronic disease. And I think it's something like 4 out of 10 have 2 or more. When we say chronic disease, it's really easy to just think that it's this one monster thing. But really, it's a bucket term for a lot of different diseases. Basically, a chronic disease is any condition that lasts for a year or longer that needs ongoing medical attention. So something that needs follow-up, something that needs treatment, something that needs management. And I had a really great mentor in medical school. He was a cardiologist who once told me that the secret to a long, healthy life is a well-managed chronic disease. And so when we say chronic disease, we really mean anything from high blood pressure or hypertension to diabetes to emphysema or COPD. Some people have heard of that. It really can be any of these things. And so when you say chronic disease, it's a really, really highly variable bucket of stuff.
Okay. So you said 6 out of 10 Americans. I had no idea it was that big. How many of those people you think would think of themselves as having a chronic disease?
Yeah, that's really interesting. Every one of them probably recognizes that they have a chronic disease. But if you ask people if they would characterize themselves as sick or unhealthy, most of them would probably say no.
Okay. And so this isn't necessarily something where people are being hospitalized, but they need to seek out treatment on a regular basis.
Right. It's something where they probably need a really good primary care provider. And we in primary care really manage a lot of chronic disease. So, for example, if you have high blood pressure, you don't necessarily need a cardiologist. As a family doc, I consider myself a specialist in common things. And so, there's a lot of high blood pressure that I can manage. There's a lot of diabetes that I can manage. There's a lot of asthma that I can manage. And if someone has a condition that gets really complicated or isn't really responding to my treatments in quite the right way, that's the point where I'd probably get a specialist involved.
So how many of your patients would you say have come in because of a chronic disease?
Well, that's sort of a loaded question, Jenny. Right now, all of them. My current job is as a primary care doctor for people with Parkinson's. And Parkinson's is a chronic neurologic disease. So right now, pretty much all of my patients have a chronic disease, sort of by definition of the clinic that I work in.
Okay. Yeah, I'm just curious, I guess, maybe for a primary care clinic or, I think I go once a year for a checkup. I suppose some people are maybe coming in more often.
Yeah, well, and so if you're a generally healthy person, you're not really on any regular medications, and you really just have a primary care doc for, when things come up, you might get a UTI, or, when winter might be particularly bad, you might catch a pneumonia or something. It's good to have a primary care doc to do your preventive health care and to see you for those kind of acute illnesses rather than chronic illnesses. But probably I would say most people who are otherwise pretty healthy don't realize that there's a lot of prevention that you can do with a primary care doc, and so they often just don't even seek care. So I would say the majority of most primary care clinics are seeing people with some form of chronic disease.
Okay, and I kind of want to go through what are the potential causes, and I know it might be varied, but I'd like to hear that. What is the experience like, and then treatment? So can we start with what are the key main causes?
Yeah, well, it really depends on which chronic disease you're talking about. And Jenny, as researchers, we know that, correlation does not equal causation. And there's a lot of association out there that we don't necessarily know is causative. Having said that, though, you can kind of go like disease by disease and probably pick out some things. So one really big one is diabetes. Let's maybe talk about that. As we all know, there's a couple different kinds of diabetes. So there's the kind that traditionally children are diagnosed with. It's due to an autoimmune reaction against islet cells of the pancreas. That's not what we're talking about necessarily here. If we think about type 2 diabetes, so typically what's been previously known as adult onset diabetes, that's a really good example of something to walk through with, where do the roots of that really lie? And you mentioned the Make America Healthy Again initiative. It's really funny. As a doctor, we want America to be healthy. We don't want people being in the clinic all the time. It's, healthcare is one of those funny jobs where really the ideal state is that we would work ourselves out of a job. Because if no one had any kind of illness or human malady and they were just out living their lives happily, number one, I would be pretty happy as a doctor for that case. And you know what? If my schedule emptied out because everyone was healthy, that would be great. I would gladly retrain into another job. Here we are. I think I was talking about type 2 diabetes, for example. And so we do know that before you get type 2 diabetes, there are certain risk factors. You're probably an obese person, or at least overweight. You're probably not terribly active, and your diet probably is not a very healthy diet. There's lots of things that have been implicated in that. So refined sugars certainly have been, highly processed foods, that sort of thing. And so when we think of, where does chronic disease come from? Really, it's sort of, what are lifestyle characteristics that then lead us as a population in the United States to have perhaps more of these diseases than other places.
Okay. So there's a lot of lifestyle factors. I suppose for some things it's genetics as well.
Correct. But there are people who no one else in their family has type 2 diabetes and they get it. And there are some people who everybody they know in their family has type 2 diabetes and they don't. So it's kind of one of those interplays of both things.
What about Parkinson's, what you're working with now?
Yeah, well, the Parkinson's population is kind of interesting because one of treatment modalities for Parkinson's is exercise. And exercise, lo and behold, also treats diabetes. And so we find that when people become very active to treat their Parkinson's, their blood sugars look better.
Do you prescribe exercise?
Funny you should mention that. We actually try to. We currently here at Intermountain, that was a perfect segue, Jenny. You're setting me right up. The Intermountain Neurosciences Institute Movement Disorders Clinic currently has an implementation feasibility trial set up where we are trying to get the healthcare system to support people to learn how to exercise in the right amount at the right intensity where we think they will see a benefit for their Parkinson's. So the little gem here that's important to know is that there's some emerging data that suggests that high intensity exercise is actually disease modifying for Parkinson's. And what does that mean? So the medications, so the pills that we have for Parkinson's, they treat the symptoms of Parkinson's. So lots of people think of the shakiness or tremor when they think of Parkinson's. So there's a medication called carbidopa-levodopa that's really good at treating that. And there's other variations on that theme. But Parkinson's still progresses, even if you are treating it with medications in the most optimal way, however you want to define that. With exercise, though, if you can get somebody exercising at 80% of their maximum heart rate for 30 minutes, at least 3 times a week, There is a lot of very convincing data to suggest that that is disease modifying, meaning that it can change the curve of how someone's Parkinson's progresses. No medications can do that, only exercise.
That's amazing. I've also heard about food as medicine, and so, writing a prescription for fresh produce. I know some folks in Kansas that are looking into this and excited about it. I think they're trialing it in Oklahoma and other states. Do you have any experience with that?
Well, so going back to diabetes as an example, there's a saying that it's impossible to exercise your way out of a bad diet. And I think that's largely true based on the patients that I've worked with. If you can get somebody to change their eating style from like the typical American diet, high processed foods, lots of refined sugars, high carbohydrates, to something that looks more like the Mediterranean eating style, that can often bring about a lot of really healthy change and either get somebody's diabetes better managed, or for some people, get them to a stage where if they showed up having made those therapeutic changes, if they show up, with better blood sugars because of it, you might not even be able to say they really have diabetes anymore. But that's a pretty rare scenario.
So I want to get into now a little bit about the experience. And I know, again, a lot of chronic diseases, but if 6 out of 10 Americans are affected, for some of them, probably maybe they take their medication and they don't think of it, but some people, it really affects their quality of life, I would imagine.
Yeah, well, if you think about going from a situation where you're someone who doesn't take any meds to a situation where suddenly you're having to take a pill every morning, or maybe even every morning and evening, that can really change your lifestyle, right? And especially with diabetes, a lot of people end up taking insulin shots or other medications. And so that really is kind of a change in how you live your life. A lot of those meds need to be refrigerated, so you need to make sure that, you have a good steady source of refrigeration. And so, if you're going on a 2-week camping trip, for example, you have to make sure your meds don't overheat or freeze, or, there are a lot of considerations there just based on managing one's own chronic disease. But that's in addition to the lifestyle changes that we doctors want people to make to manage their chronic disease. So, for example, with diabetes, it's really getting people who maybe have never exercised in their life to say, hey, you don't have to run a marathon here, but maybe just start by walking out your front door and tapping the mailbox. And when that gets boring, go to the end of the block. And when that gets boring, go around the block until you've slowly worked your way up to walking for 30 minutes at a time. A lot of these things can't happen overnight, but for some folks, the idea of walking for that long is very daunting. We have to get people to slowly train in that direction.
There's a fair share of chronic diseases that require medicine, and there's a fair share that would respond to changes in lifestyle.
Yeah, there's a lot of data that it's not really an either or. We kind of are greedy in that we want both and. Once you have a diagnosis of one of these conditions, if both diet and exercise and medications are going to help that, we want you doing both, because we want your condition to get into, we want your condition to be better managed as soon as possible. Now, there are some people who, for whatever reasons, they're either mistrustful of pharmaceuticals, or they can't afford them, or whatever the case may be. For some folks like that, they really may lean hard into the lifestyle changes. We call them therapeutic lifestyle changes. That is never wrong to make those lifestyle changes if you're going in a healthy direction. But sometimes, it's possible to probably put a little bit too much faith in what the effects of those are. And it's kind of a balance of, if you did both medications and lifestyle change, healthy diet, healthy exercise. If you're only doing healthy diet, healthy exercise, and not doing the medications too, are you losing time in really being able to get a handle on some of these conditions? Because some of these chronic diseases, if left unmanaged and kind of running rampant, they can lead to really some very serious side effects.
I imagine there's a fair share of people who can't afford to go to the doctor or don't have access, and so they're living with a worse condition, maybe going to the ER a lot. What does that look like?
And hey, policy listeners, perk up your ears, because this is a societal decision that we've made, right? So here in the United States, we have the healthcare system that we do based on certain historical factors that led to where we are. Whereas other developed nations have made other choices where they view healthcare more as a human right and as kind of a basic human need, and provide that to their population in other ways than we do. And so, yes, cost of healthcare is pretty crazy here in the United States, especially if you don't have insurance.
So, I mean, do you have experience with people who are, say, having to go to the ER more often, or just don't? I mean, I guess you see the people who are able to come see a doctor, right?
Yes, but so before working in this job, I did work in urgent care for many years. And then as a resident too, you see people from a large stratification of the socioeconomic spectrum. And, you definitely can tell that some people who had they access to healthcare in a very basic and fundamental way, their condition would be a lot better, and they'd probably be, a much more productive member of society if they had that healthcare access. But because they didn't have insurance or they couldn't get to the doctors that they needed to, their condition was a lot worse. And like I said, a lot of these conditions have pretty bad places they can go. So taking diabetes, for example. So diabetes is not something that you really feel when you have it. If you have raging blood sugars, you don't really notice it for probably several years. It's not until you start getting the side effects of having that high blood sugar that you start saying, oh, wow, maybe something is the matter here. But the problem with diabetes is if you're at the point that you're having those symptoms, it's too late to really reverse them. A lot of times you can just sort of stop them and hold them where they are. So, for example, people's vision can get really bad. You can get what's called diabetic retinopathy, and people go blind from that. You probably hear of people needing amputations because of bad infections. That can happen too. And it doesn't happen overnight. And so if a lot of those folks had access to healthcare without a lot of barriers put in front of them to get that, they probably wouldn't end up with an amputated foot or being blind. They probably could have kept that functionality.
So when I go to my doctor, they do these blood tests and all this other stuff, and I have a vague idea what it's about. They would capture something like that.
Yeah, they would. And that's part of why preventive health is so important to be supported, especially by insurance, by healthcare, by whoever's paying for it these days, and for people to go and seek it out themselves. Because especially with diabetes, we can catch it in a stage called pre-diabetes before it's actually diabetes. And have people take some action then, and then hopefully never end up on medication.
Right. And I want to get into what it's like to try to talk to people about changing their lifestyle, or even maybe say taking medication. I assume these sometimes are difficult conversations, or it takes a while. Is this something you were trained on in medical school?
It was a little bit. It's funny you should mention this. I think the best training I ever got in working with patients was actually before med school. I worked as a patient decision-making counselor in the UCSF Breast Care Center. So shout out to the folks out there at UCSF. And that really taught me to meet patients where they are instead of just kind of having this Marcus Welby doctor knows best kind of attitude towards it. I think we found through the decades that attitude really, it doesn't help when you're telling somebody you must do this. And for whatever reason, based on their situation, they can't.
Yeah. Right. So what would a conversation like that look like?
Yeah. Really it sort of depends on the patient. Let's say there's a patient who we have been doing some routine screenings on, and their blood sugar has crossed over into that zone where they're not yet diabetic, they're pre-diabetic. So essentially, I would say, well, hey, thank you so much for getting your labs done. I wanted to have a conversation about your blood sugars because the test that we got, and typically the one I order is called a hemoglobin A1C, shows that you're in what's called the pre-diabetic range. You don't have diabetes yet, but we would want to keep you at this stage from ever developing diabetes. And so can we set aside some time to really talk about what needs to happen in order to keep you keep your pre-diabetes from turning into full-blown diabetes?
Okay. And how effective do you feel? Or how effective, I guess you could talk about yourself or the profession. And like, how often do you feel like you're able to persuade somebody to change their behavior?
Yeah.
I suppose it's easier to get somebody to take a pill once a day. I mean, it would be for me personally. So I'm not rejecting
the situation and the patient.
Yeah.
So I'm really lucky in my current position. I'm able to spend a little bit more time with patients than I think a lot of family docs and primary care docs are. Maybe policy people, perk up your ears again. Through a series of circumstances, policy involved as well, policy at different levels, I would say. A lot of primary care docs have very short visit times with their patients, and that goes into how primary care doctors get reimbursed, how we view the healthcare system, what we pay for, kind of a set of, you hear about perverse incentives in healthcare all the time. And this is sort of falling into that mix of stuff. In order to properly have that conversation, you need more than a 15-minute visit with somebody. In fact, I would venture to say that very few human problems fit into 15 minutes. I mean, think about something that's potentially life-changing, right?
Yeah.
We're trying to change how someone lives their life. that conversation is going to take more than 15 minutes. And so if you only have 15 minutes, you're probably not quite as effective as you could be. But if you had 30 minutes, or for some patients even 45 minutes or an hour, you can really get into the nitty gritty of understanding their motivations, understanding what might help them make this change, and understanding the barriers that are keeping them from making these changes.
Right.
And so really it comes down to a whole combination of stuff, right? And so what is easy to do in 15 minutes? It's easy to write a prescription. And so I think, unfortunately, based on how primary care is funded, essentially, we've sort of backed ourselves into a corner a little bit about this.
Right. And it's not all on you, right? I mean, like the whole, I don't know what the system is, but like the whole, their community, the broader healthcare system, it's not all on the physician, right?
True. It's absolutely not. But if you think about, there's a phrase that's pretty popular in healthcare, and I'm going to bungle it. So apologies to the wonks out there who are going to look up this quote and say, well, she got it wrong. It goes something like this: that every system is perfectly designed to create the results that it does, even if those are not the intended results, right? So if you think of what led to, John Smith getting diabetes, for example, it's going to be a whole lot of things. Some of them healthcare related. So some of them, healthcare industry related. Some of them John Smith related. Some of them probably based on where he lives. Does he live in a food desert? Does he have access to fresh fruits and vegetables? Does he have to eat a pack of Cheetos every day for lunch? What's he drinking? Is he drinking, water to hydrate himself? Or is he drinking a Mountain Dew to hydrate himself?
Yeah.
How much does he have to walk in the course of a day? Is he someone who just, jumps in his car, goes to work, parks in front of the building, goes in the building, and he walks, maybe 1,000 steps per day at most? Or is he somebody who has to walk a mile to the subway, get on the subway, go to work, walk half a mile to his office? And so by nature of his commute, he's getting, 3 miles round trip of walking there. And so there's a lot of factors that go into it like that. And so you're right. It's not just on the doctors. And there is some personal responsibility too. We get some patients who say, well, it doesn't hurt, or I don't feel any different, so I'm going to ignore what you say. But then unfortunately that leads to the bad outcomes.
Right. And can you talk a little bit, I know, again, wide range of chronic diseases, but the quality of life, you said 4 in 10 Americans have 2 or more. And so that has to affect just your quality of life, maybe your mental health. Like, what do you think about that?
Well, mental health, that's its own set of chronic diseases too. It's awfully hard to hold a job if you have a chronic disease that, maybe the medications have side effects that make you feel sick. Maybe it's hard to manage the chronic disease. And so the side effects of just the disease itself, or the symptoms of the disease itself, are hard to manage. Let's say you have something that makes you, feel nauseated all the time. It's going to be hard to hold down a steady job if that's the case. If something puts you in chronic pain, gosh, it's awfully hard to keep a steady job if your brain is being occupied by a constant barrage of pain signals all the time. And so when we think about policy and health, it seems very cruel to expect people to hold down jobs with certain chronic diseases. Now, some of them, absolutely, you can hold down a job. And especially if they're well managed, you can hold down a job. Right. This identifies sort of where there's often a conflict between being able to live your life and hold your job and be, a productive member of society versus someone who is trying to manage a chronic disease. Now, not all chronic disease is the same there. So I need to make sure that's clear. It gets very complicated very quickly.
There's probably some overlap, but I'm just thinking, you talked about chronic pain. I thought about the opioid epidemic or broader issues with drug use. Do you see any overlap with that in your work? I guess it like sort of the direction of causality, I'm assuming, could work in both ways. If you're managing a stressful disease, you maybe want to use drugs, or maybe drug use could lead to a chronic disease.
Yeah, sort of more complicated than that, really. Okay. I don't think anyone ever asks for, especially addiction, which is really a chronic disease. No one ever asks for that, right? Most of the time it's people who speaking of the opioid epidemic, it's people who don't want to hurt, right? There's lots of different kinds of pain, and I'm sure there's a chronic pain specialist who will probably be rolling their eyes as I try to talk about this. But, there are certain medications that we know are habit forming. For opioid pain medications, sometimes in as little as 4 days of use. And so I think whenever we talk about different conditions that need a longitudinal or a long-term treatment with certain medications, we can't put all those medications in the same bucket. Some of them are a lot safer than others. Some of them have a lot more data to support their long-term use than others. And sometimes, unfortunately, as we saw with the opioid epidemic, sometimes not all of the data gets to the people who are writing the prescriptions in a timely manner.
I wonder now if we could pivot to agriculture and food a little bit, because we're in the business of producing food. And I'm curious, what is the role of food or different types of food in chronic disease?
Yeah. Oh, there's a huge role. Food absolutely impacts. And there has been some really good research over time showing that, what we eat really does sort of produce there's this thing called health span. So if you think of lifespan as the duration of, how long you're alive, health span is this concept of how long you're a healthy person. And there are certain parts of the world where there are people who both have very long lifespan as well as health span. Okinawa, Japan is one of these places, parts of the Mediterranean. Some people call them blue zones. But there are places where, for whatever reasons, the lifestyle there supports good health. And so if you look at somewhere like the Mediterranean, that's why we have this thing called the Mediterranean diet. Right? It's a style of eating that seems to be supportive of better health overall.
Right.
Better rates of heart disease, better rates of diabetes, and in some places, better mental health statistics. Basically, people living their lives a little bit healthier than in other parts of the world. And really what you eat or what they eat has a lot to do with that. Because if you think of the Mediterranean, it's not like it's a deprivation diet, right? Like Italy is known for its pastries.
Right.
It's the combination of how they eat and what they eat and how much they eat that is really, really making a lot of the difference there. And I believe also that their lifestyle, how much they walk, how much they are exercising and active, that also plays into it.
Right. I mean, food is a part of the culture, way of life, too. You're meeting with friends, you're having certain foods. So maybe I'm just kind of spitballing here, but maybe some places just have better locally, naturally occurring food. I don't know if it's seafood or whatever. Maybe it's easier in some places.
Yeah, I suspect it is. But, it's funny because knowing that this is a policy crowd that we're talking to today, I think you really can start putting some pathways together and connecting dots between, for example, what crops have we historically supported with our farm policy? And if there's a lot of those crops, and obviously you think about the markets, and that gets to affordability and how much different foods cost, that kind of, you can sort of connect the dots. And again, causality being really hard to show probably here.
Right.
But you probably could make a link, at least anecdotally, from what crops we're supporting and how we're supporting them, how they come to market, what those markets look like, and getting to what do people see on their table. Yeah,
absolutely. Yeah, I mean, fruits and vegetables will probably always be more expensive than things that are made with flour, but there's a lot that goes on in between.
What does it take to get a carton of strawberries into my refrigerator? It takes so much, right? There's immigration policy built in there.
Yes.
There's transportation and infrastructure built in there. There's interstate commerce built in there.
Yeah.
That package of strawberries is and there's world markets too, right? Like a lot of strawberry growers are selling their produce overseas as well, and that's supporting a big part of their business. And
Absolutely.
So, when you think of that carton of strawberries with all the nutrients that go into strawberries, there's a lot of other policies that get baked in there that lead to how many strawberries I'm buying, basically.
Absolutely.
During the pandemic, I joked with my spouse that what I liked going to grocery stores because as long as I saw that they still were stocked to at least some degree, it was a sign of a highly functioning society still.
Yeah, that actually is, again, not my primary area of study, but for a couple weeks you couldn't get everything you wanted when you wanted it, but there was always enough. I guess sort of the patient experience, the sort of struggles that people go through as they, I guess especially the people that don't just come in with one thing that can be treated fairly easily. But, again, this could be a third of the struggles of you come in, you maybe have one or two things. Your doctor maybe mentions to you briefly, eat better, exercise. Maybe you're in a place where you get more time. That kind of, and then, you have to manage a medication or taking a shot. That has to be a lot for somebody.
Well, and especially if I can underscore this diet and exercise piece and not, beat the dead horse here, but there really is something to that, where how you grew up really can then set you up for success or failure in eating and being active in healthy ways. And so it's really supporting people who didn't grow up with really knowing what vegetables to buy or how to prepare them, or even how to buy vegetables, right? There's a wonderful episode of King of the Hill, if anyone watches that show, where they eat an organic or homegrown tomato for the first time, and it's like mind-blowing because they've only had just your conventional grocery store tomatoes that don't really taste like anything.
Man, a fresh cherry tomato from the garden is mind-blowing.
The color's not that red. It might be a little mealy. It doesn't really taste like anything. Yeah. And so if you haven't grown up knowing those things, if you grew up in a place that didn't have access to fresh fruits and vegetables, or maybe those sorts of things were expensive and your parents didn't buy them, or it was just easier to throw together, some hamburger helper because that's an easy dinner, right? If you don't grow up with these healthy habits, where do you get those? And so in the healthcare industry, I can't speak about the healthcare industry at all, but as a doctor, I try to support my patients in learning those things and learning how to eat and be a healthy person if they didn't grow up with that. And again, kind of there's a lot that gets baked into how well I'm able to do that based on time, based on, how receptive the patient is, and also just based on things that I can't control, things that are outside of my clinic. Is there a place for them to even get healthy vegetables, fruits and vegetables within their affordability range?
Right. And there are groups out there that work on this. I mean, I assume.
There are. In some places more than others. Having gone to med school in Chicago, I think Chicago has a really interesting food scene and trying to get food access to everybody. Here in Utah, it's a little bit of a different landscape, right? So we grow a lot of our own vegetables in the summer. The joke here is if you don't lock your car in the summertime, you may come back to find that someone has placed a bag of zucchinis in it.
It's Utah.
That's true. Everywhere, zucchinis tend to just take over. If you buy zucchini in the summertime, it means you don't have friends.
Seriously. I guess there's a lot of, there's, culture, access to resources, access to healthcare, styles. Yeah. There's a lot that sort of contributes to what people are suffering, from these different diseases, how the system works.
Right. Well, again, every system is perfectly designed to create the results that it does. And what we have to ask ourselves, I think, is not, what little lever can I pull over here, but what's really going to change the system to one that, and it's not just what happens in my clinic that's going to do that. It has its roots in agricultural policy. It has its roots in, how we design our transportation networks. It has its roots in what we as a society want to put our tax dollars to.
Yeah, absolutely.
And I think that's sort of at the end of the day, it's understanding that big ecosystem that we live in, and how do we set that up for health, that I think is going to be an interesting thing to tackle in the years to come.
Right. Well, there's something I'm asking people. If you could change one thing, like policy, otherwise, what would you change? Is there's one thing that you wish people knew about what you do?
Well, can I give one?
Take a bit.
So I wish that people knew that doctors don't get kickbacks from writing prescriptions. It drives me bonkers when people think that I'm only writing a prescription because somehow, I get paid to do that. I don't. Or if I do, Pfizer's sending the checks not to me, but to someone else. No, we doctors don't get paid. We don't get kickbacks like that. Are there some unscrupulous doctors who maybe do, but
How often do you hear that?
Actually, with some regularity. Unfortunately.
Accusing you? Are they curious and asking you, or are they kind of accusing you?
In situations where I've done a lab test or I've looked into something and I said, oh, hey, your blood pressure is really high. We should think about, I give them the whole diet exercise thing, ask them to cut back on their sugar. But at a certain point, if that hasn't really helped, I say, at some point we should probably think about putting you on a blood pressure medication. And there's a look on some people's faces that they get where they're trying to understand your motivations for making that recommendation. And I often say, I promise I don't get any kickbacks from drug companies for writing a prescription. And a lot of people actually look relieved and they're like, oh, thank you for saying that, because I do actually wonder that sometimes. And it breaks my heart when people think that doctors, at least, mainstream doctors, that we do, because we don't. To answer the other question of if I could change one policy thing, There's lots of arguments about what people call socialized healthcare, but if I could change something, it would be, I wish the United States provided healthcare for everybody living within its borders, because we're one of the richest countries. Our health quality metrics are garbage. We pay a lot for very little in this country. And it frustrates me to no end that we can't be a healthier society. And there are things that have been shown to support that and things that don't. Sadly, I think we're going about the whole thing the wrong way.
Yeah. It's definitely tough.
I will say that there's a lot of doctors who've given up hope on getting their patients to live healthier lifestyles, but I've found a lot of success in getting people to change how they're living. A little bit of education goes a long way. So I've had some patients who've never exercised a day in their life. And we talked about everything from how to buy a good sturdy pair of walking shoes and shoes that fit. Like, don't go for the coolest looking ones. Go for the ones that feel the best on your feet. We've got, I've talked to them everything from that to literally kind of what I said earlier on. Honestly, just start by walking out your front door, standing on your front stoop and breathing the air. I will take that as a start. And you can say, you know what? Dr. Sakata told me that counts as exercise for today. But I don't want you to stop there. I want you, again, do that for a week. But after a week of doing that, I want you to go down and tap the mailbox on its head. Do that every day. After that, I want you walking past the mailbox, walking to the end of the block, and slowly, incrementally building up exercise. And I've had patients who, again, never exercised a day in their life, go from that to like walking for 2 hours altogether. They're like, hey doc, like I just put on my earbuds and now I go out the door and I walk for a couple miles. And that's amazing. And all of their chronic disease metrics show it.
Yeah. So, again, I think everybody would agree we have a very imperfect healthcare system.
For sure.
And it's not going to work for everybody, but for a lot of people, there are things that they could do that could help for a lot of people.
Yeah, and I think there's a lot of, an ounce of prevention is worth a pound of cure. And part of the way our healthcare system's set up right now is we don't support the prevention. Well,
thank you so much for your time. We've covered a lot of ground. It's given me a lot to think about. Is there anything else you want to add?
I think I might actually just recap a few key points. So number one, chronic disease isn't one thing. It's a lot of different things, and different policies can affect each separate chronic disease in different ways. Number two, I would say, is an ounce of prevention is worth a pound of cure. And there are things that we could be doing as a society to just have a baseline healthier society. And number three, we doctors don't get kickbacks for writing prescriptions. We just want you to live a healthy life.
Absolutely. Thank you so much for your time.
Thanks for joining us on this episode of Smoke and Mirrors. If today made you think or see things a little differently, share it with someone who appreciates cutting through the noise. Don't forget to subscribe, rate, and leave a review wherever you get your podcasts. Thanks for spending part of the day with us. Until next time, keep asking what matters.